I've really been feeling like without folks talking a lot, we are clearly starting to head towards that tipping point. I'll tell you what I mean more about the tipping point in just a moment. But it's fascinating to me that we did not get all the speakers on a conference call before this summit happened, and yet there has been this theme through everyone's talk that is basically around social justice and how racism impacts health and the work that we're doing. To me, that is a sign that we as a state are making good strides in the right direction. I also want to note that it's not lost on me that my oldest daughter is 20 years old today. So 20 years ago, I was in labor. I remember every second of it. And the other fun thing about that is I get home last night, she's home on spring break, and she's doing some video chat thing with her buddies from Earlham College, where she attends a group of young women that started an organization last year called the Center for Gender Identity Inclusion. And they were having a conversation about an article that they had read on maternal mortality. And I said, what are you guys talking about? Oh, we read this really cool article, Mom, and we're talking about it. It was written by this woman, Dr. Joya Creer-Perry. Well, I got to be the cool mom for a change and say, well, I've met Dr. Joya Creer-Perry. And they were all very impressed. So I had my moment of glory as a mother, right? You know, you all know you got to take it where you can, right? So another sign in my heart that we are headed clearly towards that tipping point. You already know our vision: zero preventable deaths, zero health disparities, and there's been a lot of great talk about that in the last day and a half. So the tipping point, if you go to Malcolm Gladwell's book, you know, it's that magical moment when an idea sort of, you know, is sparked, hits, you know, somebody, somehow, some event kind of throws kerosene on the fire and it spreads like wildfire. Lots of sociologists have written about this. I think Malcolm Gladwell sort of presents it in a way that's easy for most of us to understand. But one of the key take-home points from that book and from this whole concept is that little things end up making a huge difference. So it isn't necessarily that we're going to find the secret sauce to solve racism. It's one little step at a time, and all of us coming together, and all of these speakers, without anybody being told, somehow having some understanding of what really needed to be spoken about, that ends up tipping us to the point where we have a nation that's presenting families with the option that Dr. Beck and his colleagues are presenting them with. Speaking of Dr. Joya Creer-Perry, I mentioned this quote to Dr. Gray, and then I couldn't find it before his talk, and I was able to find it, sorry Herman, for myself. But I think it sums it up in where we're really trying to head. It isn't race that is the risk factor, it's racism. If you've heard Dr. Creer-Perry speak, she's quite passionate about this. And this is, if you want to look this up and more of the writing that's associated with this quote, it's in, go to the Black Mamas Matter website and you'll find it. But this is where I think we have to be headed, folks, where we are doing our work every day based on this. Okay, so that's a little background about tipping point and where I want us to get to. I said in the program that I was going to talk to you a little bit about the foundations of the improvement plan. Our tagline is Together Saving Lives. So I want to take a little step back. Now the other thing, and you're going to see, the other way in which I think we are headed to the tipping point is that I have some of the same slides that Dr. Beck had, so which really he just made my job a lot easier, right? I'll be able to go through this a little more quickly. But first, I want to take a step back. I asked members of the Maternal Infant Strategy Group to respond to how is mother-infant health created. So woven throughout this talk are some quotes from those folks. This one from none other than our dear friend, Dr. Renee Kennedy. Maternal and child health are created in context, the context of where mothers and babies live, work, play, pray, and the experiences that evolve in those contexts. The experience of moms and babies often are characterized by poverty and wealth and can be gendered and racialized. All factors that can countermand the creation of health is not addressed intentionally, if not addressed intentionally. So these thoughts are woven throughout the talk in order to give you a sense of where the strategy group was coming from as they were reviewing the plan and providing guidance and input into the plan. So here is the exact slide, only animated, that Dr. Beck presented a little bit ago. This, as he said, comes from the Robert Wood Johnson's Foundation's work on county health rankings. I cannot encourage you enough. Every single person in this room needs to go home and fire up the World Wide Web and go to RWJ's website, County Health Rankings. Every single county in this country, with I think the exception of a handful, they have mapped and ranked the health rankings. Those health rankings are based on length of life, life expectancy, and quality of life. Now, one of the things that's interesting to me about their quality of life measure, it includes low birth weight. Because low birth weight, it turns out, is a great marker for a number of things, not just infant mortality, but developmental delays, school readiness, all kinds of things. Kind of, if a baby starts out too small, it's not generally a good course for that infant. So do take a look at those. I'm going to show you Michigan's in a moment compared to our low birth weight rates. But the thing that I think Dr. Beck already spoke to much more eloquently probably than I can is that if you look at our improvement plan, we're pretty much on that top 50%. We're at the clinical care setting. We're talking about things like substance use, certainly tobacco, talking about access to contraceptives. So we're very much in that 50% that they're estimating has to do with clinical care and what they call health behaviors. We absolutely have to get to the bottom half of this, right? We've got to get to housing. We've got to get to economic development. I'm going to talk a little bit about some ideas we have to get there. I think infused in all of this, I don't care how you break the graph down, what you put next to the bars. Again, infused in all of this is going to be addressing racism. And I think you cannot listen to Ms. Irving yesterday and not be thinking that we've got to pay attention to that and come up with some solutions. So key objectives of the plan, high level, this is the 30,000-foot Mother-Infant Health and Equity Improvement Plan is explicitly addressing disparities. We did use that terminology purposefully, kind of the outcomes subset, if you will, of the larger issue of health equity, aligning the private and public sector, and integrating the work across the maternal-infant dyad. I want to share a bit of a video from Dr. David Williams, a conversation that he has with Don Berwick at IHI. I only have 10 more minutes, you're telling me? Really? I don't think that's, okay, what time do we go to? Then you guys really should have told me. That's not true. Okay, all right. I think Dawn's timing me, apparently. Okay, we have time. Okay, thank you, though. That's okay. We could cut it right down. So Dr. Williams is from Harvard's School of Public Health. Google him. He has amazing TED Talks out there, great stuff to say. They're having a conversation about racism in healthcare. And the part of the video I want to play has to do with implicit bias. And they're talking at the Institute for Healthcare Improvement, which is clinicians, so insert home visitor, insert public health nurse, insert whatever you are into this conversation if you don't happen to be a doctor. So bear with me and fingers crossed that the second video works for the day. I'm not going to make you listen to the whole thing.
To minority patients. Can you help us understand a little better this implicit bias use? So I'm a doctor, a patient comes in, white, African American. What happens in my conscious or unconscious or in the interaction that becomes a generator of the kind of inequity you're talking about?
It's a great question. What the research shows is that most of us, and this is about not white people, this is about human beings, most of us think that we are driven by our conscious cognitive conditions. In fact, a lot of what we do occurs at a level beyond our conscious awareness, and is importantly driven by ideas and narratives and stereotypes that have been deeply embedded in us as part of the culture or the society in which we were raised. There's a lot of research that indicates that in American culture, African Americans, for example, are presented as lazy and dangerous and violent. Those are negative characteristics. Healthcare providers are part of the larger society. Research using the implicit association test, which is one test that tries to get at these unconscious implicit biases, finds that over 70% of all Americans have an anti-black bias. And the number for physicians is also over 70% because they're part of the larger society, we are products of the culture. So it does not reflect then the behavior of bad people. It reflects the behavior of normal Americans who are reflecting the biases and the messages about race that they have received. Importantly, what the research shows is that when we have this negative implicit bias, this negative stereotype, even though we personally are committed to egalitarian principles, without our conscious awareness, when we meet someone who fits that stereotype, we will treat them differently and honestly will be unaware that we did it because there was no intent on our part. And that's why it's called unconscious, unthinking discrimination. It's implicit, it's not explicit. You're not looking at that person and saying, I'm going to discriminate against them. In fact, if I asked you if you did, you'd say I didn't because there was truly no intent. So it's something that we need to raise awareness levels of. There are a number of strategies that can be used to help clinicians and all persons become aware of this tendency that we have. The other point
I'm going to stop it there. What I love about that piece is, first I want to say occasionally I do think there is intent, unfortunately. But what I like about that piece is that he is making the point that if you come up in a world that teaches you things that are inappropriate, things that are wrong, things that are ugly, you have really very limited chance as a white person, or he even goes on to say all groups have their out-group. But certainly in the case of racial relations, I'm going to talk as a white person, I don't have a huge opportunity to not have some negative biases in me. I have said many times, that's a sin, but that's not the biggest sin. The greater sin is doing nothing about it. And there's another video at the IHI website, but we don't quite have time for all of them, where he talks about more the solution. And he has this lovely little video out there about the divine solution. Dr. Pat is her, I can't say her actual full name, Divine, who has done a lot of the work around implicit bias training and testing. And we can do something about this. So that's one of the things that I think is going to get us to that tipping point, is to start to, as a community, think about in our own organizations, how do we do this work? How do we start to get everybody trained? It's not just about getting people to train, but I think that's one of the first places we need to start. Okay, now I'm not moving forward, Laura. Laura's sort of my human security blanket. I told her she had to sit up front in case I had trouble. Thank you, ma'am. Okay, so many of you have seen this slide. It's in the improvement plan. We've been going around the state with it, town halls and other meetings. We are very much committed to the notion that we've got to work to get to that broader level of health equity and sort of the bigger umbrella of health equity. Like I said a few minutes ago, we're using zero health disparities at the moment as part of the vision, in part because we think we've got to take some steps down a path, and to a certain degree, which I'll talk about in a moment, some of that path we kind of need to figure out how to do it best. But one of the things that we do think will help quite a bit is to be using our data to drive decisions, to drive programs, to drive interventions. This is that map that I told you I would show you a few minutes ago. On the left, the greens is from the county health rankings at Robert Wood Johnson. This is sort of an example of some data that we can use as we build more equitable solutions in our state. You'll notice that the dark green are the ones with the worst rankings, basically. Wayne County, no surprise, I'm sure to anybody in this room, is ranked at the bottom, very bottom of this state. You see that area in the tip of the mitten. We were talking this morning about how we all have our Michigan, and that's very much driven more by poverty, as well as up in the UP. When you have a chance to go to the website and dig into these sites, what you will see are bottom quartile of counties in this state tend to be more of color, and they certainly are poorer. As you go up the rankings, it becomes whiter and wealthier, no surprise, right? But part of why I wanted you all to see this is if you go to the website and you click on those counties that are in your region, there is a wealth of information about what's going on behind all of this. So I want to encourage you to do that. The map on the right, and I'm going to give a shout out to my friend Chris Fussman that's over on the far side of the room. He's rolling his eyes at me right now. Chris is one of our epidemiologists, and we have a great team of epi folks at the state, and they're always in the background. They never get their moment of glory. So on the other map, and I think it's interesting, again, that's low birth weight in this state. Those are clusters of low birth weight babies. And you see a lot of blue in those dark green counties. Now, as I told you, those dark green counties, part of their measure is low birth weight. But it is interesting to me, maybe it's just my epi kind of brain, but it's interesting to me to see that it indeed does overlap, right? One of the things we're doing, and we'll talk about in a couple of minutes, is working with the collaboratives to take a deeper dive into all of this sort of data. The EPI folks have been working very hard to come up with region-specific data that we're going to take out to the collaboratives because we are asking the collaboratives to start moving a little more towards a population health model, and which is what you see here. It's using data to identify the populations that are most likely to have the adverse outcome and stratifying it. It was good to my heart to hear Dr. Beck talking about they're using risk stratification as well. And what all stratification means is sorting folks into most likely to have a really bad outcome and less likely. Now, in some of these areas, that gradient is pretty small, but I still think as we could tease that apart, we might find some clues, particularly if we're talking to the communities and the families that are experiencing those outcomes. We might come up with some really good ideas of things that we could take on that are very specific to a given neighborhood. And then, in other words, the next thing on this is create an intervention that works for that group. We need to implement it, and we do need to measure what we're doing, because if it's not working, midstream, I say let's stop and come up with another idea. I don't want to wait 3 to 5 years to find out that, oh, gee, we still haven't impacted rates. So in Prosperity Region 10, just a quick example, Southeast Michigan, that collaborative, SimQuick as they go by, are already using some data like this to take a deep dive into their home visiting. This happens to be preterm birth on the left and low birth weight in those 3 counties on the right. they are at the level of the 2 zip codes in the city of Detroit that have the highest incidence actually of infant mortality, which of course have the highest incidence of low birth weight in preterm labor. What they're doing is basically trying to address that issue by getting more women to home visiting, by increasing referrals and enrollment into home visiting for the women that are eligible for that. So this is just a quick example of the kind of thing we are working with the collaboratives. Other collaboratives are also already doing it. I'm just using Southeast Michigan as a quick example. And just giving you the high level view of clearly on those maps, there are clusters of folks that are more likely to experience these outcomes, and you all know the drill. What goes along with that is a lot of poverty, a lot of poor housing, etc. So again, back to our call to action for health equity, addressing systemic inequities is critical. There's not much in the plan right at the moment about that, in part because we feel pretty strongly we got to eat this elephant one bite at a time. And we only, as you all know, maybe even better than I, we don't have enough resources to do all the work. That's not an excuse. That's just a way of saying we are feeling we need to be very strategic about the work. And we think we need to learn a little more about the path to figuring out how to address inequities. We've already seen this, so don't even have to use that slide now. So I do want to recognize a project. Dr. Renee Kennedy and Amy Zagman approached the Health Endowment Fund last spring, wrote a grant, and we got it funded. It's the A-BEST project, Achieving Birth Equity Through Systems Transformation. I think this will absolutely be another thing that's going to help us get to that tipping point. They want to ultimately, if we're going to take on systemic racism, we have to understand how to change systems and how that is operating within the system. So Dr. Jennifer Torres and her team, Jennifer, are you here? Oh, there she is. So you can ask Jennifer about A-BEST at the break. They will be trying to figure out root causes of some of the maternal infant outcomes that we're trying to change, shifting mental models so that people are thinking more about structural oppression and social determinants of health within an organization, and then engaging a broader community of partners. We absolutely think we don't have all the right people at the table. One of the other things we think is critical to getting to that tipping point with health equity is inclusive decision making. I think many of us have spoken at this summit about the need to have families at the table. And this room needs to be, we need 100 moms, dads, aunties, neighbors that are just concerned about their neighbors in this room. We as professionals cannot be making decisions for these folks. They know what they need. They know what's going on in their neighborhood. We have got to get them to the table and have a real voice at the table. We've got a way to go with this. We have started. I hope Nina Sassy was able to hear Dr. Beck. I don't see her in the back. Oh, you are back there. Great. Because Nina is working very hard on the ambassador program. And what we envision is some of what Dr. Beck just talked about. Groups of people around the state that are coming to meetings and sharing the voice of the folks, but are also on their block advocating for what folks need, knocking on doors, telling women about breastfeeding, getting them connected with WIC if that's what they need, so on and so forth. This is a picture of one of the first groups that met down in Southeast Michigan. I see a nice big smile on Nina's face. It's got to feel like a lot of hard work coming to fruition to see that picture up on the screen. So talk to Nina if you want to know more about that, but this is something we really are looking to grow moving forward as one of the pieces of getting more families' voices to the table. Okay, the last thing is this notion that I teed up with Dr. Williams' video about implicit bias in social justice training. There are things out there called affinity groups or white folks doing their own work on racism. Lots of good things going on out there. I think our organizations need to be taking this on. I also think that we all personally need to be taking this on. So go out to the website. Michigan Public Health Institute, Center for Health Equity has some great information. There's a group out there called Allies for Change. In the Kalamazoo west side of the state, there's a group called Erase. Google it, there's a lot out there. And see what you can maybe do with, within yourself, your social group. I think, sometimes getting a group together, reading a book, reading some articles, and having some discussion about them might be a great way to start. But we also need leadership within organizations sort of taking this issue on. So we're going to be working on that as we move forward. So Peggy Vandermeulen, a lot of you know Peggy, tireless advocate for families. Peggy is part of my personal story in doing this work. When that daughter that was born 20 years ago today was an infant, I first met Peggy at a Healthy Mothers, Healthy Babies conference. I think it was in Mount Pleasant that year. And she made a very eloquent comment. This is 20 years ago, folks, when people were not standing up in meetings and saying it's all about racism. And she stood up, and that's exactly what she said. So I asked Peggy to share some thoughts with us. She's at the AmChip conference, so couldn't be here today. Otherwise, she would share these thoughts with us herself in person.
Good afternoon. I'm sorry I can't be there with you in person. Lynette had asked me to say a few words about why and how white people should work to create an anti-racist world. So why? Well, because whites are responsible for creating the concept of racial hierarchy for the sole purpose of dominating and oppressing people of color for economic gain and power. Those of us who are white, no matter our ethnic background or perceived lack of individual racism, still benefit from the power structures and policies that were put in place to protect that white dominance. We are unwitting benefactors of the whiteness we were born with, through no merit or fault of our own. To quote scripture, to whom much is given, much is required. As a white person and a person of faith, I have a moral responsibility to use my privilege to dismantle the unjust systems that oppress others, whether or not my ancestors or I are personally responsible for creating those systems. So, how do we work to dismantle racism? First, acknowledge the reality and ongoing impact of racism. Second, acknowledge the reality and benefits of white privilege. Third, move to action. Here are a few ideas to get you started.
Sorry, I didn't really mean to do that. But that was probably a good stopping point. I can tell you her call to action is just what I already just said, to join an affinity group, go to some implicit bias training, etc. I'm thinking about time, and I apologize for cutting that off so abruptly. I would like to leave a few minutes for discussion, so I'm going to kind of jump through some slides here and talk a little bit about what we are asking from the department, from the strategy group, a bit of a call to action. We've said this several times, and so I'm sorry, but we really want you joining our monthly newsletter, connecting with the perinatal quality collaboratives. We really want you attending the MyHEC meetings. I said yesterday we get a little over 100 folks, and we want at least 300 there. The next one is at the Samaritan Center in Detroit. We probably can't fit 300 people there, so do register in advance, and we might have to move. And that is on May 9th. As we've already said, think about some training or completing an implicit bias scale. Think about going to an affinity group. One of the things that I think is critical that I want to say in closing, First of all, I have to always say when you see this slide, this is Laura Drayton. I couldn't make this slide if my life depended on it. But isn't it cool? I just love this slide. It's I think we've got everybody working together, right? But who don't we have? Okay, the one thing we don't have, are what I call the unusual suspects or the social determinant of health sectors, right? Unlike what Dr. Beck's managed to do in Cincinnati, we don't have housing at the table. We don't have the economic development folks at the table. You better believe I'm going to be finding out tomorrow who those 7 legal aid projects are in Michigan. Did anybody know about that? Okay, I got to find you folks. A few folks did. I had no idea that we had some of those in this state. There are very interesting examples around the state where they are pairing legal aid with the healthcare community for the very reasons that Josiah's mother needed it. So with that, I greatly appreciate your patience and listening to me today and having an open heart to the message. Very much more so appreciate the work that you all are doing. It definitely, as we've said many times, it's a heavy lift. However, I happen to think we are up to the task. We're strong, we're smart, we can do this. We can do this together, and we can get to 0 preventable deaths, 0 health disparities. Now, would anybody like to ask a question or make a comment? Yeah, please. It was a really easy question. No, thank you. It's a critically important question. Can I quick pass the microphone to my friend Renee Kennedy? So, did everyone hear the question? I think is the first. Okay, I'm going to hand her the mic.
Are you serious? No, I'm not Renee. This is Renee. Oh, okay. So my question was, listening and hearing address racism, and not in just this presentation, but several times. I'm just wondering, as it applies to the state's plan, when you say that, how do you conceptualize it? So what does that look like? And then how do you operationalize it, meaning going forth and doing the work? What does that look like? And then who bears the responsibility of accountability and all of that, addressing racism?
Thank you for the second mic. Yeah, you want the honest answer? I don't know is the honest answer. I do know that we have a moral and ethical responsibility to try to figure it out. I will tell you what I think. I don't know if I'm right. I think that it starts in all of our hearts. I think it starts with our own individual work. And from there, and I think, I didn't say this, there's someone at the department that does this work that says, and it starts with each and every one of us, and we all have to do this work with humility and grace. I think Peggy might have mentioned that in her comments. So that's where it starts. I don't know how I necessarily hold people accountable to that, other than to be sharing that message and delivering that message. Then I think our organizations have to be held accountable to looking at diversity in hiring, to looking at the structural racism that exists within all organizations. There is no one that I know of that is in a position to, other than every single person in this room. I think that's, for the moment, where the accountability comes from. I am trying to look at Renee to see if I'm even halfway there. She's giving me a little thumbs up. This is really hard. I really honestly am saying, I'm building the bridge. I'm happy to be out on the front of the bridge. If I fall over, I hope you all are going to lift me back up. I think that's where we start.
I mean, that answers the question, but I guess, it was great seeing Peggy, the video.
Yeah.
But I always feel like when we're talking about racism, it's more acceptable for someone white to say, oh yeah, this is white privilege, racism. However, when I'm in the room sitting at the table as possibly the only woman of color, if I even so mention implicit bias or racism, it's like I have horns coming out of my head. So I'm trying to figure out, as a Black woman, when we talk about racism and addressing it, how is that operationalized in the context of trying to create change?
And Dr. Kennedy, go ahead, Orlando, get him to clap. Dr. Kennedy did volunteer to take this one.
I'm happy to defer. But, so it is complex, right? We didn't get here overnight. We're not going to depart this place overnight. We use a model of thinking about the personal, interpersonal, institutional, and cultural level. And you have to assess where's your sphere of influence. So if we are all singing our solos in our sphere of influence, it becomes a raucous chorus, right? So thinking about being intentional about acting and not just saying. This is an action, it is a verb, and it looks different in each of our spaces. I remember very clearly I was the only person in my space ever saying diversity, quite candidly, when I was at the College of Nursing at Michigan State University. And then all of a sudden, more people were saying it. And I was walking about conference rooms and hearing people talk, and like, am I missing a meeting? No, my colleague. So it is incremental, but I would submit that incrementalism can still be rapid. You can take small steps quickly. So we'll build it together. None of us have the precise answers, but the answers are available.
And, I absolutely believe we're going to get to that tipping point one step at a time. In the front,
I guess to join her a little bit, I was hoping to hear maybe that there's a committee in place that's actually dedicated to that, and then maybe strategize to, come up with a plan of action or something like that. Maybe that's what I was hoping to hear when she asked the question. I know it does start with every single one person and, every single one area or organization, but we're talking about statewide, and it keeps being mentioned to almost every meeting. So we were hoping to see a bigger picture, like, okay, this organization will deal with that, and maybe you can make the connection, you can get involved, you can do this, even though we are doing it individually. Yeah, I think that's what I was hoping for a little bit too.
okay, I'm going to take that as official input into the improvement plan. We have how much? 1 minute. Okay, one more comment, question. Over here, Dr. Holtrip is really trying hard.
I just want to give an example of how complex this whole issue is. I'm a physician, I'm a pediatrician, and I have connections to the neonatologists in the state. And there was a study that came out that said there was implicit bias in NICUs in terms of how African American babies were treated compared to white babies. And the initial response was, oh no, not here. And then there was a commentary put out by someone who was, I think, I'm not even sure, she wasn't from Michigan, it was somebody from, I think, California or whatever, who was a neonatologist and said, yes, I actually never thought about it, but yes, I recognize now that I did treat babies who were African American differently. And it had to do with, maybe the African American mothers in the NICU weren't there as often, and so I automatically kind of stopped trying to educate. Or maybe I was afraid, maybe the African American mothers that I was dealing with, a lot of them might have been very, very stressed. And maybe I stepped back and didn't engage with them as much because of fear. And I think that was a very powerful, powerful statement that this person made. And then I mentioned this to somebody else here in the state who's a neonatologist. Oh no, I don't treat a white neonatologist. I don't treat babies any differently depending on their race. And so there comes the complexity of trying to just get people to even recognize that there is an issue, because as a white person, I can tell you this, the immediate feeling, and it happened to me here as I was listening to Dr. Williams talking, was like, no, I don't do that. No, I don't do that. And I loved what the lady that
Peggy.
gave the audio, said about, now I've lost my train of thought, but just being able to acknowledge it to yourself and to be able to say, we benefit from the structure. We may not feel like we have any responsibility in having created that, but we benefit from that structure as a white person. That makes it easier to go to the next step of saying, oh, there is an injustice here and we do need to address it. But you got to get people to that point, because you're absolutely right. You mentioned you're the only black person in the room, and with a bunch of white folks, you're going to get that, yes, you're the evil person, because the immediate response is always, oh, there we go again.
Sorry, we have to have one or two more. If you have to, we're gonna, I'll get to you, dear. We're just moving rooms, so I think we can take a few more minutes, but if you want to walk out, feel free. We'll respect that. Yeah, go ahead, this gal right here.
Hi, I am a staff nurse in labor and delivery, and this just hits me right in the heart of an issue that I've been thinking about a lot, but feeling powerless. What do I do? You know, what do I do as a white woman who has opportunities that are not available to other people just by where they live, the color of their skin? And so I have choices. I can feel guilty, or I can be brave and have a conversation and say, what can I do? And I think the first step is to take a look at what does implicit bias look like, and not from a place of judgment, but from a place of curiosity. Because once you see where something that, implicit meaning you weren't aware of it, none of us thinks that we have racism or prejudice, but it takes hard work to take an honest look at our heart and what we do. Sometimes what we think we do and what we actually do are not the same thing, and that takes courage to look at. So what I would like to do personally to start this journey is, one, to look at myself, honestly, talk to my friends. What do you see in me? Because if it's implicit, guess what? I don't see it. You need your friends of all different nationalities, to put in on that, to weigh in on that, and then challenge your friends to do the same thing. We all work with women, we all work with people in this sphere, and if we all challenge each other and then go out and challenge our friends, they go out and challenge their friends, guess what? We'll win this together. Thank you.
Okay, there's a woman in a black and white sweater, and she's been trying really hard to get in here. Thank you for your comments.
Well, actually, what I wanted to say is make a comment. I really appreciate this open discussion. I mean, I am a health provider, and I've been in a room as a woman of color many times for many years, and this is the first honest discussion I've sat through. So I really appreciate the open conversation. So it was very heartwarming to see that it has not just started, and we're not the only state that's doing that. So I really appreciate that.
Well, my people that are around me a lot are getting tired, I think, of me saying over and over and over again, we have got to have the conversation. And it's not going to be easy, people. It is not going to be easy. But we've got to have it. I know, Nina. Please, one more. I keep saying one more. Okay, we got one over here. So be quick, Cheryl.
Another easy question. No, I'm just kidding. I think my personal charge, this is a great conversation, and I think my personal charge is to be a steward of equity. Equity for women, equity for children, and equity for all humans. So I think that when we're looking at ourselves, and whether it's implicit bias or whatever, we start with ourselves first, and being a steward of equity on all fields is the first step in the right direction, I feel.
Okay, Kadada Green, one of our strategy group members, I'm going to get you in here, and then I think probably Nina's going to tell me I have to stop. the conversation?
I
Hang on, we'll let you speak.
have the mic, I have the mic, thank you. No, so I just wanted to say that there is a way for accountability when it comes to racial equity in the work. And it's really within the practices, policies, and attitudes of whichever institution and organization that we're talking about. And there are tangible ways to honor Black motherhood, and there are tangible ways to really respect motherhood and babies and their humanity. And one of those ways is really, roll my thoughts down, it's about having checks and balances and also a feedback loop. And so there are ways to do it, and so we really have to look at ourselves and those implicit biases, but you also have to be explicit about what your practices are, what your policies are, and what your attitudes are. And you sometimes you have to draw the line in the sand and say, hey, here's what we're doing, this is the way it is, and if you don't like it, then we have to keep moving forward, and some people get left behind. But accountability, there can be accountability, and there's ways to do it. So look at your practices, policies, and attitudes, and do they reflect those that honor Black motherhood? And if they don't, then there's work to do. But really, really have checks and balances in place. I just want to.
Thank you.
Can I just make a closing remark?
Please.
So I want to invite everybody to embrace their angst right now. Because a bunch of people are feeling like, this is good. Because this means we've gotten to a place of authenticity. I'm going to submit to my colleague and friend, Lynette, that maybe next year at the summit, we really dig deep to do work together. To have a couple of keynotes, but really to break into sessions, to get into who am I in this space and what is my active response to this space. Because there is action. You may not know what to do right now or know what to say, but there are strategies and there are things to say. There's a way to have a dialogue that keeps people whole, keeps people at the table, and advances change. I know it because I've done it and I've seen it. So I just want to invite you to not leave this space feeling like, oh my gosh, this is why I don't want to talk about race because it's so uncomfortable. This is good. Discomfort is good.
Okay, thank you, Dr. Kennedy.